I'm pleased to be able to talk to you today in relation to bronchial thermoplasty. And just to start off, I'd like to say that I have no conflicts of interest that I need to disclose. I haven't received any funding in relation to any of the work that I'm going to show you. So we're going to be asking the question, is bronchial thermoplasty a potential light at the end of the tunnel, or is it just the tunnel at the end of the light? And there are many questions in relation to bronchial thermoplasty, and I've listed some here, and no doubt you might have some further questions at the end that I'll be happy to answer. But I thought I'd work through these questions with you this morning as a platform for further discussion. So let's start off by talking about what bronchial thermoplasty is and how it's done. And you need two pieces of equipment to do bronchial thermoplasty. Firstly, on the right-hand side of the screen, you need the radio frequency generating box, which generates 10-second electrical charges, which are passed down this catheter here over on the left. The catheter is placed down the bronchoscope into the bronchial tree, and it's opened. And at the apices of the four arms here, there's bare metal, and it's around these bare metal contact points that the electrical current is passed, which heats the surrounding mucosa up to 65 degrees for a 10-second burst. And we treat different parts of the area of the airways serially, and I'll try to show you that with a little video shortly. We do it in theatre. To make it, it's a painless procedure, but it's a longer bronchoscopic procedure than normal, taking maybe 30 to 45 minutes, and therefore we do it under a general anaesthetic. Here's an airway and the catheter in sight, and you can see that the catheter's got little markings along the side which show us how deep we are into the lung, and then we progressively bring the catheter back more proximally to completely treat that airway segment, as you'll see in this next little video, if I can show it. Just stick with it. Hopefully it's going to show all right for you. This is a live bronchoscopic procedure that we are doing. You can see that we're advancing the catheter into the airway there. If there were audio, you'd now hear the burst of electrical charge, and then we'll bring the catheter back by a 5mm excursion and then treat the next area. So I'll just stop that now. It's pretty straightforward. The procedure by convention is done in 3 treatment sessions. Firstly, treating the right lower lobe, then the left lower lobe, and then the upper lobes. And this was designed really because it was worried by the people who designed the procedure that there'd be the potential to make patients with severe asthma more wheezy, and therefore the procedure should be done in a staged approach. Also, by convention, the right middle lobe isn't treated, and that was for concerns about producing a stenosis at the origin of the right middle lobe. Although I understand there are some centres now in the United States that do treat the right middle lobe and that there isn't actually a problem. In the States, they treat people by day case because of the high cost of bed fees in the States, but we prefer to do it with an overnight hospital admission. And this suits us because we now tend to do much more severe patients that previously have been done in the United States. And we follow the way in which the Europeans generally do the procedure. We pre-treat people with prednisolone before and after to reduce any post-procedure wheezing. So where is it done and by whom? So this little cartoon shows you in white the centres that are currently actively performing bronchial thermoplasty in Australia. There's 2 centres that no longer do bronchial thermoplasty, one because one of the hospitals is closed and the other one because the main protagonist has moved from Western Australia. Even so, the numbers of patients that have been treated with bronchial thermoplasty in Australia are small. So these are catheter sales I've obtained from Boston Scientific, the manufacturers. We need 3 catheters per patient because we do it in 3 treatments. So if you work that out over the last 5 years, there's only been 150 patients treated in Australia, or about 30 patients per annum. And the numbers are fairly static at the moment. How does it work? Well, this histological photo of an airway shows normal lung on the left-hand side and asthma on the right-hand side. And there are a number of key features we look for in asthma histology, but one of the key features is this hypertrophied airway smooth muscle layer here, which is obviously much thicker than the airway smooth muscle on the normal side here. And it's this hypertrophied airway smooth muscle that, if you like, is the effector organ in causing bronchoconstriction in patients with asthma. And this is the target of bronchial thermoplasty. So in the initial studies that were done of bronchial thermoplasty using a canine model, here's the airway histology pre-treatment, this is post-treatment, this is the airway smooth muscle layer, and this was after treatment of 12 months. And you can see that there's really obliteration of the airway smooth muscle in that case. Now, it doesn't happen to that dramatic degree in humans, but this was the proof of concept for the procedure. These are before and after endobronchial biopsies, however, done in humans, and they've used the brown stain to show actin, which is a feature of airway smooth muscle. And you can see there's a lot more brown staining in the pre-treatment pictures compared with the post-treatment pictures. And this has been quantified as well. So now I'd like to talk about how well does the procedure work. And the starting point should be the 3 randomized controlled trials that were done in bronchial thermoplasty over about 10 years ago now. They all went for 1 year. There was one smaller study in more severe patients, but the 2 bigger studies are in less severe patients with asthma. And I'd highlight to you here that the outcomes of these randomized controlled trials showed positive effects, but mostly in patient-determined outcomes such as symptom scores, symptom-free days, rescue medication use, and exacerbation rates, but really not so much in lung function type parameters such as FEV1, except for the more severe and quite small study that was done. It's difficult to do really good randomized controlled studies in surgical procedures. And this was a landmark study really because the patients in the sham group still went to theatre, still had a bronchoscopy, and the bronchoscopist was also blinded to whether the bronchial thermoplasty setup and machine were working correctly. And in this, the AIR2 trial, you can see measured at the 12-month period, a significant reduction in severe exacerbations, emergency department visits, and hospitalizations. This slide shows you the change in the quality of life score. This asthma quality of life score, a higher number represents a better quality of life. And to explain the x-axis here, these are patients who deteriorated, these are patients who stayed the same, and these are patients who improved. And this is the placebo group, and this is the bronchial thermoplasty group. And you can see that more patients improved in the bronchial thermoplasty group and less patients deteriorated over time in the bronchial thermoplasty group. The criticism of this trial has been the large placebo response, and we know that we do get a large placebo response in many surgical interventions, and in most randomized controlled trials, even of medications, there's a very significant placebo effect. This was greater than would normally have been expected in this trial, but nevertheless, the active comparator was still significantly more effective than the placebo effect. In terms of follow-up after these randomized controlled trials, we've got published follow-up of each of them at 5 years, showing that there's been no deterioration over time in the effect, no amelioration of the effect, reduced exacerbations still maintained out to 5 years, and no signal to suggest that there's any safety problem with the procedure. And furthermore, they're just about to publish the 10-year follow-up data from this AIR2 trial, and I expect that will be published in 2019, showing the same thing. This gives you an idea of the reduced emergency room visits being maintained out to 5 years. And this is a summary of the long-term safety and effectiveness of the procedure, showing no changes in CT scans evident at 5 years, no deterioration in lung function, and no attenuation of the effect of the bronchial thermoplasty. Now, at the most recent European Respiratory meeting, they also published the results of the global post-marketing registry, really the European registry, although the Australian sites, including ours, were part of that registry, showing the 1-year results. So this was an open label, single-arm observational registry of 18 countries, and they reported the results of about 130 patients. The analysis was based primarily on severe asthma exacerbations, but there were secondary outcome measures as well, such as medication usage and hospitalizations. And here we see the significant results, a significant reduction in exacerbations at 1 year, emergency room visits, hospitalizations, and unscheduled office visits. So the post-marketing registry results really reflect the results that were seen in the randomized controlled trials. And we've also got some similar data in Australia. This is the data from 70 patients in the Australian Bronchial Thermoplasty Register. And after 6 months, it looks like there is a non-response rate. So about 83% of patients respond to treatment, about 17% of patients don't, based on an improvement in the asthma control questionnaire of the greater than 0.5 being the minimal significant clinical difference. Being a surgical procedure, technique probably matters. And we've published some work trying to look into why everybody doesn't respond. Why is there a non-response rate? And we think that the more treatment you give, the more effective the procedure. And we've been able to show that in this small paper looking at the outcome of 24 patients. I'll just skip over that. And we've also published some information to suggest recently that the instrument size is important, that a smaller bronchoscope facilitates treatment. But people are still looking at what factors predict non-response to bronchial thermoplasty so that we can target those factors and increase the response rate, because obviously patients don't want to have a procedure if it turns out that it's not going to benefit for them. So we have looked, for example, at whether it makes a difference whether patients have reversible airflow obstruction or fixed airflow obstruction. So this was a group of about 40 patients. Each patient is represented here, or actually it's 47 patients. Each patient is represented here on the x-axis, and their starting ACQ is represented by the orange dot, and their post-treatment ACQ is represented by the blue dot. And you can see that the majority of patients are improving, and there are one or two exceptions. And here we've divided the group of patients into those with reversible airflow obstruction and those with fixed airflow obstruction, and it really didn't seem to make any difference. And that's good news for these patients with fixed airflow obstruction, because there have been historically less treatment options for these patients. For example, they don't qualify for the monoclonal antibody therapies often. So then I thought we should talk about who is bronchial thermoplasty for and how does it fit in. And I wanted to remind you that asthma is a big disease with many components, but with the therapies available to us, the majority of patients are going to be well controlled, and we don't need to consider bronchial thermoplasty for those patients. It's the small segment at the most severe end of the spectrum that bronchial thermoplasty becomes a significant consideration. And that poorly controlled slice of the pie has a number of different forms. There are those patients who truly have poorly controlled asthma, but there are those patients who look like they have poorly controlled asthma but would be well controlled if they were more compliant with their medication. And then there are those patients who don't have asthma at all, but who have some other disease, who've been mislabeled as having asthma. So how do we identify that truly poorly controlled slice of patients to start off with? And the things that we look for are patients who've not been smokers, who do have obstructed spirometry, who are receiving triple therapy in substantial dose, yet still use frequent reliever medication, frequent bursts of oral corticosteroids, have a high ACQ and a normal chest CT scan to exclude emphysema. And of course, they fit into the ERS-ATS definition of severe refractory asthma. And in fact, all the patients in the Australian Bronchial Thermoplasty registry meet this definition. You only need one criteria to qualify, but most patients qualify on 3 out of the 4. And reminding you then that in terms of the GINA framework, at the moment we consider bronchial thermoplasty here at the step 5, the most severe end, something we add on for patients who are on triple therapy, but who have remain poorly controlled with frequent exacerbations. So what are our options for that sort of patient? Well, we could do nothing. That's not a good option for the patient. Or we could put them on maintenance oral corticosteroids, which is what we have historically done in the past, and which we also know is a poor option for patients because of all the long-term side effects of corticosteroids. Or we could choose a monoclonal antibody, bronchial thermoplasty, or more recently, chronic macrolide therapy. So how would one compare perhaps monoclonal antibody therapy with bronchial thermoplasty? Well, they're similar, but they're also different. So you need acquisition costs for bronchial thermoplasty in terms of buying the equipment initially, and then you've got the cost of the 3 hospital admissions. So it's likely that bronchial thermoplasty, in fact, would be more expensive over the first year of treatment than a monoclonal antibody, where we're normally paying about $30,000 per annum. But bronchial thermoplasty, of course, is a one-off expense, and therefore over time, it's very likely that the cost of monoclonal antibodies, being a recurrent annual expense, will progressively overtake the cost of bronchial thermoplasty. As far as we know, the monoclonal antibody therapy is lifelong, whereas bronchial thermoplasty is one-off. Both are highly effective. The monoclonal antibodies, of course, we now have good biomarkers that tell us who to target the use of those monoclonal antibodies for. We don't yet have good predictors or biomarkers for bronchial thermoplasty. Both treatments have safety. Both treatments have withdrawals, even the monoclonal antibodies. Not everybody responds, and some patients will have an adverse effect that causes withdrawal. I think, being physicians, we would choose a monoclonal antibody if the patient qualified as our natural first step, and keep bronchial thermoplasty in reserve for those patients who either didn't respond to the monoclonal antibody or who were unlikely to benefit from the monoclonal antibody. And this has been reflected in a recent editorial from Neil Thompson, where he's suggesting in this framework that patients who can get a monoclonal antibody go down this limb, and then they would only come over to bronchial thermoplasty if they didn't respond. And then the other group of patients, which might be 40 or 50%, not suitable for monoclonal antibody therapies, might be considered for bronchial thermoplasty. I do think that up to now we've been concentrating on dividing patients into which of the two arms they follow. But I think in time, increasingly, we'll come to see the treatments as being complementary. We have many other examples now where we don't consider the surgical option as being an exclusive alternative to the medical option. But all options are really part of the mix. And I think in time we'll see the same sort of thing with bronchial thermoplasty. And it may be, for example, that a patient who might be receiving mepolizumab for severe asthma, but whose asthma control questionnaire still indicates poor control of asthma, the patient not being able to get off oral corticosteroids. This might be a group of patients that then has bronchial thermoplasty on top of receiving a monoclonal antibody. What about who's bronchial thermoplasty not appropriate for? Well, when the diagnosis is not asthma, so coming back to the point that this is a treatment that targets hypertrophied airway smooth muscle. So if the patient doesn't have hypertrophied airway smooth muscle, for example, if they've got COPD, then this is not a treatment for them. We wouldn't be suggesting it when the asthma was well controlled. We tell patients that bronchial thermoplasty is not to be considered as an alternative to them taking their maintenance medication. Of course, we want them to come off oral corticosteroids, and we find that at least 50% of patients can come off oral corticosteroids, but it's not an alternative or a cure that is going to mean that they no longer have to take their maintenance medication. What about the lower limit of FEV1? Well, in the United States, they have a lower limit of 50% based on the 3 randomized controlled trials. But that's not so strictly adhered to in the rest of the world. And now in our Australian registry, about half of our patients, in fact, have got an FEV1 at baseline between 30 and 50% predicted. And we're finding that those patients have no increased risk of adverse effects from the procedure. And one would expect that the treatment was equally effective, possibly even more effective for patients with greater airflow obstruction at baseline. The presence of a pacemaker or a defibrillator is a contraindication to using the radiofrequency technique, so those patients can't have BT. So now let's talk about the complications of bronchial thermoplasty. And I thought I'd start by showing you these 2 pictures that I've taken on a particular patient. This was taken immediately before bronchial thermoplasty, and this was immediately at the conclusion of the procedure. Now, I've chosen a fairly extreme case to show you, but you can see that obviously the mucosa is looking inflamed and edematous, and clearly we've been fiddling around down there. But when we come back 4 weeks later to do the other side, you can now see that that same segment looks perfectly normal. One even gets the impression that the airways might be a little bit more dilated, which is what we would like to see. We've spent some time measuring the change in FEV1 before and after the procedure. So this is, we would measure the post-bronchodilator FEV1 immediately before the patient goes into theatre, and then 24 hours later. And on average, we see a fall in the FEV1 of about 10%. But this is well tolerated, and it's uncommon to cause the patients a problem. And we've then measured that FEV1. This is the 9% fall on day 1, but then if you on day 3, almost come back to normal, and day 7 back to normal, or even better than normal, probably because of the oral corticosteroids used to cover the patient for the procedure. So short-lived, slight deterioration in lung function producing wheezing is a common side effect, but not one that causes much of a problem. So here we've looked at the serious adverse effects from 210 treatments in 70 patients. There weren't any deaths. There was a chance of the patient staying longer than the expected 24 hours, but that occurred in about 6% of patients, and it was usually only 24 or 48 hours longer than expected, and usually the reason was wheezing. A few patients did go to intensive care immediately post-procedure. None required intubation, and none were in intensive care for any prolonged period of time. And a few patients have been readmitted within 30 days of the procedure. And this has been for various things. For example, one patient had melena, which possibly was contributed to by the steroids. One patient had urinary retention and needed a TURP, again possibly contributed to by anticholinergic medications. One patient had pneumonia on the treated side and needed intravenous antibiotics. All patients made a complete recovery. And then lastly, I thought we'd just have a little look at the costs. So the box that you need to perform the procedure costs $50,000, which sounds like a lot, but in medical equipment terms is fairly slight, really. The catheters cost $3,000 each. In Victoria, that's more than compensated for by the revenue that the hospital receives from the government for each procedure. And so our hospital is very happy with the financial arrangements. There's no direct MBS item number, and that has, to some extent, stunted development of the procedure in the private sector, although the second largest, having said that, the second largest centre in Australia is a private one, that's Macquarie Private. So by way of conclusion, does it work? Yes, it's our experience that it works in about 83% of patients. We have no question that it's safe and it fits in for patients that are GINA stage 5. And I might stop on that note and ask for questions. Can you hear me, Steve?
You sure can. Just unmuting our microphone here. Don't worry, final slide there did get a laugh from the audience. You just couldn't hear it. Well, thank you very much, David, for an excellent presentation and working through step by step through all the questions and issues that are around bronchial thermoplasty. So as mentioned, for the online audience, if you have any questions, you can now enter them in the question panel in the GoToWebinar software or within the chat window if you prefer. And I'll take any questions from the audience here in Newcastle. Peter.
Thanks, David. That was great. Can I ask you some questions about subject selection?
Of course.
Any experience with brittle asthma? What's the outcome? Any experience with the very old? And also people with an abnormal CT, so maybe coexisting bronchiectasis or fibrosis.
Okay, so I'll take the last one and work backwards. There always has been a theoretical concern that, you know, whether bronchial thermoplasty would aggravate somebody who had bronchiectasis, and we have chosen to avoid doing patients who clinically had bronchiectasis, that is overt bronchiectasis. In terms of other CT abnormalities, within the Australian cohort, there is a smoking rate which I think might be about 15% from memory, and there are some patients that have got more than a 10-pack year history, but we were convinced enough that the diagnosis was asthma to go ahead. In some of those cases, we've actually done an endobronchial biopsy to demonstrate whether there was airway smooth muscle hypertrophy. In the research patients that we've been doing at Frankston, we've been doing more comprehensive CT analysis and measuring an emphysema score. And in most cases, the emphysema score is very low, always less than 10%, commonly around 3%. So we have been targeting people where the main diagnosis was asthma. And of course, from a clinical perspective, it can be quite difficult to know whether the patient that you're seeing has the predominant diagnosis of COPD or a predominant diagnosis of asthma or both. And that's why we've sort of been using the CT and the endobronchial biopsy as well as the normal historical features plus the asthma biomarkers to try and build up a picture of what we thought. And I think that there's a role for MDT discussion of that sort of patient. So that's the third question. The second question related to older patients. So I didn't show this in the slides, but the randomized controlled trials were done on a less severe group of patients who were younger. I think the mean age was about 49. The mean age for the Australian patients is more like 60, and we have patients that we've done who've been 75, 76, 77. I don't think we've done anybody who's 80, but so I would say that older patients are common, and I suspect that that's the effect of age causing more pronounced, maybe more fixed airflow obstruction in patients who've had asthma all their life. So I think that that's a common group that we deal with, and we haven't found that age is a factor in terms of diminishing the response to therapy. But just remind me of your first question again, Peter.
Brittle asthma. So does it?
Brittle asthma. So by brittle asthma, do you mean people who might have normal lung function one day and then a very severe attack the next?
Yeah, so sudden catastrophic episode.
So I don't have much experience with that group of patients, but I've had patients over the years in the past who unfortunately have been in that category and who have died, and I have thought that bronchial thermoplasty would be an excellent treatment for them. I do have personal experience with one patient who has done extremely well, who fell into that category. This particular patient had a medical background and in fact had their own VPAP machine at home that they could put themselves on when they'd exhausted all the other usual treatments. And they quite frequently had to use their VPAP machine for an exacerbation of asthma. And then since treatment, their life been completely turned around. But I know that's only one case.
Thanks.
David, maybe I'll ask, so you mentioned a good responder rate, I think it was 83%.
Yeah.
I was just wondering, relating to the non-responders, you also mentioned, so the bronchial thermoplasty occurs over 3 procedures for every patient.
Yeah.
But there's a range of numbers of activations over those 3 procedures for each patient. I wonder if you could comment on whether there was any trend with the non-responders on where they fell in terms of the number of activations they've had. Would you consider more activations, or is there any indication that they're not responding because of the number of activations, or is it more likely something inherent about their disease pathology that's not responding?
Yeah, well, I think it's a very good question, and it's one that we're exploring. So our first publication in relation to activations concerned our first 24 patients. Now that we've got a larger cohort, we want to go back and try and better identify those factors that might predict poor response. And one way to do that might be to look at compare the group of the top quartile for response with the bottom quartile for response and see what factors were different between them. And then having done that, we might then go on to do a multivariate analysis. So we've been waiting for our numbers to be large enough. But it is something that I've been thinking about, because so far nobody else has identified predictive factors for non-response in bronchial thermoplasty. And it makes me wonder whether it's more about the technique than about the clinical factors of the patient. Maybe some patients are less responsive to that degree of heat than others, and you would think, being biology, that there would be people who'd be more responsive and less responsive. And we've got one patient that has signed up to be retreated. We haven't actually done the retreatment yet. He's one of our most severe asthmatics. He did improve with treatment from an ACQ of 6 down to an ACQ of 4. There's been really no improvement with monoclonal antibodies, and he's in the last 12 months has never been off 30 milligrams of prednisolone, and he received, when we did treat him, he received a lower number of activations. And so after careful discussion with him and with our ethics committee, we've decided that we are going to retreat him and then report that as a case, and it'll be interesting to see what the outcome is.
Right.
Peter.
David, could you say something about models of care? What's optimum, what's essential, and what's the role of MDTs in this process?
Yeah. So, well, I guess the first thing to say is that we wouldn't accept a referral from anything other than a respiratory physician. We expect the patients will have been well worked up in the same way that we would expect patients to have been well cared for and worked up in terms of applying for a monoclonal antibody, that there must have been a substantial period of interaction with the patient. We must be happy that the patient is compliant with their medication, etc. So all of that. In our hospital, we have MDTs for a number of diseases, like obviously interstitial lung disease and lung cancer. We're just at the stage of having an MDT for interventional pulmonology, but some other institutions, for example, Alvin's Institution in Macquarie, have a well-established interventional pulmonology MDT, which is a good idea. Models of care. We're fortunate in that we do have a severe asthma clinic that our patients come into, being secondarily referred by their respiratory physician, and we have active clinical respiratory research nurses who assist with patient interaction, patient evaluation, and care coordination. Then, in relation to the procedure itself, I'm very comfortable with the way we do it, that is a general anaesthetic and an overnight stay, particularly since we do so many patients with more severely impaired lung function. And I'd be uncomfortable if we went to an American model of same day, although, you know, we have had plenty of patients who, at the end of the day, having had their bronchial thermoplasty in the morning, have said they'd like to go home, but our standard of care is that they stay overnight. And in saying that as well, I don't think that this procedure fits well with the way we did bronchoscopy when I was a registrar, which was basically local anaesthetic and no anaesthetic support. I think it's immeasurably valuable doing these cases in a proper theatre setup with an anaesthetist. Post-procedure, nebulized therapy, oral corticosteroids, and these things are not foreign to the patients anyway. And a contact number to ring after discharge if there are any problems, and obviously we schedule the next procedure before they leave hospital. And then in terms of post-procedure evaluation, we've been routinely seeing our patients and evaluating them 6 weeks, then 3 months, and then 6 months, and then 12 months, and ongoing every 6 months thereafter. Does that answer your question?
Yeah, that's great. Thanks.
John Harrington has a question here in Newcastle.
Thanks, David. Do you have much data on those people that have been treated with monoclonal antibodies and then have had complementary bronchial thermoplasty? I'm assuming it would be monoclonal antibody first before having BT.
Yeah. So we know that a fair percentage of our patients have had a monoclonal antibody prior to bronchial thermoplasty, maybe 20 to 25% off the top of my head, but not all of them will still be on the monoclonal antibody. Many of them will have had a trial of the monoclonal antibody and then it's been discontinued. Actually, there's something else I'll say about that in a minute, just reminding myself. In terms of the other way, we have patients who've had bronchial thermoplasty and then moved on to a monoclonal antibody. I would say that there might be 10 to 12 or 15 even in that category. I have not been struck that there's been any diminution of the effect of the monoclonal antibody in those patients. They've done well. Something that I haven't shown, which I think is interesting, is the baseline eosinophil count of the Australian registry patients prior to January 2017, when mepolizumab became available, versus the eosinophil count after that date. And it's clear that there's been a change. So the mean peripheral blood eosinophil count was about 450, I think, prior to the availability of mepolizumab, and the mean eosinophil count now is about 200. So it's clear that clinicians are making an informed choice to use a monoclonal antibody first. Does that answer your question?
Yes, thank you.
And I guess, so you mentioned in terms of the positioning from the expert opinion there of monoclonals first when available for the phenotype, and then bronchial thermoplasty afterwards, or if there's no monoclonal left. I guess it sounds like you're saying there's also potentially a position for monoclonal antibody after bronchial thermoplasty.
Well, the patients that we would have had that have fallen into that category would have been people that had bronchial thermoplasty a couple of years ago before the availability of the IL-5 antibodies. So, whereas the ones today, in general, they'll already be on the anti-IL-5 therapy and have not responded adequately. Either not responded at all or not responded adequately.
Right. And what would then be your process hypothetically of a patient on, say, mepolizumab with a partial response, but not, say, adequate, to then receive bronchial thermoplasty? Would there then be a discontinuation of the mepolizumab, or I guess then you get into very complex decisions?
Well, I think it's a very interesting question that I was talking to Pallav Shah about a couple of weeks ago, the possibility of a worldwide trial of looking at bronchial thermoplasty on top of mepolizumab. And the questions would be, do you do it and then randomize people to withdrawing the mepolizumab or continuing the mepolizumab? That would be one possible trial. Or do you restrict it? This is the way I would do it, is you would only offer it to people who had an ACQ, say, of more than 2 on mepolizumab, and then you randomize them to receiving BT or continuing treatment as is. But either way, they still keep getting the mepolizumab. So it's an add-on treatment for people who are poorly controlled. I think that would be a good trial to do.
Very interesting. Any more questions from the audience? I think we've exhausted the questions here, so I'd like to finish by thanking David very much for his presentation. The recording will be available on our website in the future. And join me in thanking David.
Thank you, Steve. Thank you, Peter. Thank you, everybody, for joining.